So next speaker is Deep Dalwa.
Thank you so much, Sophie. Good afternoon, everyone. Thank you to the course organizers, Sophie Dang, Dr. Patel, Dr. Lee, for really planning an amazing Cornea Day. But really, most of all, thank you to you all for staying till the bitter end, and I hope to not disappoint. So just for starters, not your typical red eye. Thought I'd make it exciting. Here are my financial disclosures, none of which are relevant. So here's the case. Let's put it all together. We have a 68-year-old woman with a history of rheumatoid arthritis and Parkinson's disease. She's sent in for a second opinion for a red eye that she's had for 2 months. And she's been treated by a community cornea specialist. So the first thoughts before examining the patient, when I think of rheumatoid arthritis, of course, we're worried about scleritis or PUK, et cetera. And when I see a patient, or am about to see a patient with Parkinson's disease, I'm worried about exposure keratopathy. This patient came in on already erythromycin ointment 4 times a day and systemic antibiotics as well, and no response. So actually, the diagnosis I was happy to see was simply conjunctivitis. So we did a culture, and it was a simple Staphylococcus aureus, not methicillin resistant. So we treated with becifloxacin, and she resolved nicely. So I thought, hey, this is pretty good. However, she returned 4 months later and said, my eye is red and goopy again. Now I need your help. What should we do at this point? Here's the audience response. Please pull out your phones and help us decide what to do at this point. Should we culture again? Forget cultures, just restart the becifloxacin, or just forget cultures and becifloxacin and just start ciprofloxacin. So we'll have a little music. It's my favorite part. Okay. All right, smart audience. So took your advice, and we'll go back to the presentation. And this time it grew heavy MRSA, resistant to fluoroquinolones, sensitive to vancomycin, tobramycin, gentamicin, and bacitracin. So when I saw her, of course, there was no improvement. Still had copious discharge, copious. So we switched her to tobramycin, did an antiseptic rinse, and she comes back a week later. I thought, okay, we got it, we nailed it. She was only slightly improved. She was still not happy, neither was I. Still with discharge. So then we planned to just start an ointment for better contact time and switch the antibiotic up to gentamicin. And then I thought, if she doesn't get better, I'm switching to vancomycin. We also did another lavage with an antiseptic. So she comes back a week later, and she definitely had less discharge, but she was still quite hyperemic and now was developing a possible contact dermatitis. So we stopped the gentamicin, continued the bacitracin, and we started Lotemax, QID. And now look at the date. So it's 9/18/19. And I thought, if this case doesn't get better, what am I going to present? I'll look like a fool. So she came back, and indeed, she looked great. Thank goodness. So her discharge was resolved, her redness resolved. So happy patient, but happier doctor. All right, so what is this entity? Diagnosis? Giant fornix syndrome. Okay, so what is this? This is a chronic, relapsing, copiously purulent bacterial conjunctivitis in elderly patients. And these patients will have symptoms for months to years. It's typically Staph aureus, but recently we're seeing more methicillin-resistant staph. So what happens is they get a levator dehiscence, a deepened superior fornix, a poorly functioning tear pump, and then they get proteinaceous and bacterial coagulum, similar to a biofilm. So the important thing is also they get a secondary toxic keratopathy with severe punctate epithelial keratitis, vascularization, thinning, and even, in some cases, perforation. So again, here, now you know what the diagnosis is. What is the correct therapy? You saw me muddling around there. Another audience response question here, so if we can go to that. Is it topical antibiotics only, topical steroids only, a combination? Should we have put her back on the systemic antibiotics, or should we have just taken her to surgery right away? So audience response, please pull out your phones and help us out. Okay, let's see what you say. Yes, a combination, indeed. So I agree with you, and we'll go back to the presentation. Here we go, published therapeutic options. So there's a lot of published therapeutic options. The most important thing is, though, in this case, topical antiseptics have a very, very important role. So we used povidone iodine lavage and hypochlorous acid to kind of mechanically sweep and lavage. So you really have to get up there with swabs and really get this coagulum, this biofilm, get all that stuff out of the eye. It's not just simply using drops and hoping this goes away. You have to actively get it out. And so we wanted to use the antibiotics to make sure she was responding before starting the steroids, and in this case she had a resistant organism. There's also been reports of subconjunctival antibiotics and steroids. And then a surgical option is definitely employed as it's clearing to really improve the anatomic problem. You should rule out the NLD obstruction as well. Here are the pearls when you see a patient with a red eye. Always do a nice external exam. So in this case, this patient has an extremely floppy lid, and unless you really touch that patient, I think the key here with this red eye symposium is turn the lights on, step back, and do a really great external eye exam. It takes literally 5 seconds. And then, just to show what that povidone iodine squirt is like, this is actually the way I prep all my pre-op surgical patients. I imagine that they actually have giant fornix syndrome, all of them, and I'm getting rid of all that coagulum before I enter the eye. So I'm really cleaning the ocular surface before I enter. So this is just a routine cataract patient. He never had a red eye, and this is how we prep everybody. And we do this in the holding area and then take them back into the operating, and he winks, yes, he's a good guy. And then they have another prep in surgery. So, in summary, giant fornix syndrome is often misdiagnosed, mistreated, and under-recognized. It's a very important cause of chronic purulent conjunctivitis with secondary toxic keratopathy. There's lots of treatments, use all of them. Don't forget to do the mechanical swabbing and irrigation. Lots of references. Thank you for your attention to my children, and please come visit us in Pittsburgh. We're opening our new Vision Institute in 2022. And please submit your abstracts for World Cornea Congress. Abstracts are open until 10/2019. It's going to be a wonderful, wonderful meeting. Thank you.
Thank you so much. It's a great case.